Dear chairs, ladies and gentlemen, it's my pleasure to hear talk. The personalized management of patients with diabetes and CVD. Well, so what is personalized diabetes treatment? It is well known. According to patient different conditions, why we have to amplify. Since we not amplify personalized in China, particularly in China, the community hospitals. So I have got a chance. We opened the first diabetes studio named after my name. So this is a very good chance to understand the detail of the community doctors how can manage diabetes. They start from the 2017 and 2019 since stopped in 2019 since the COVID-19. Then we found the community cluster sampling studied on diabetes. Surprising for me, the highest detected another metabolic disease is atherosclerosis, nearby the 80%, followed by the NAFLD and obesity. So the atherosclerosis and obesity and NAFLD usually compared with type 2 diabetes. Then I know detailed information in real time and real world. So the doctors in the community hospital, they usually according to guideline from the Chinese guideline or India guideline or the guidelines. So the first line, the medical medicine choice, such as the metformin. The second line is low blood glucose. The drugs can choose third line the insulin, and so on. But for what is important things, the different patients, different conditions. So we published the paper, the 2023 and the following years, 24. The ADA also emphasized the best on the BMI. So how can the individualize the treatment recommendations based on the BMI? So different BMI, we should be different the drugs they command. For example, just the couple of the professor that mentioned initiation the insulin therapy. That's good, but still we believe that if the low BMI less than 24, so we strongly recommend initiation with insulin therapy, but not in the BMI bigger than 30. So that's the part different. So that means individualized, personalized. Also metformin, you can see metformin, we don't recommend in the low BMI persons, right? But in the high BMI, we recommend the big dose, more than the 2 grams per day. So for insulin, if the BMI person bigger than the 28, we don't recommend them with insulin, except the complications. So this is a little bit different. I still believe personalized is better. So I would say with the times don't like the detailed introduce the based on the BMI, using the hypoglycemic drugs and choose the amount of method of exercise and choose energy intake based on BMI. So this should be familiar with. Well, as yesterday I mentioned we proposed a new syndrome, metabolic inflammatory syndrome. What's happened? So we found that the 4 disorders, including atherosclerosis and fatty liver, obesity, and type 2 diabetes. So we recommend that if the patients with 2 or over than 2, above 4 metabolic disorders, it was diagnosed as metabolic inflammatory syndrome. A syndrome, usually it has common source. And what is common source? What is the common pathophysiological process? Here, we studied to show that the LPS is related factors. The LPS coming from usually coming from disbalance of gut microbiota. Disbalance of the microbiota. So LPS bind to macrophage receptor, macrophage receptor, toll-like receptor 4. Then they inhibit the microRNA 145. Actually, it's inhibit promoter. Then they increase the 2 compounds. For example, the MGF4, so induce the NKP system, then produce inflammation. So initiation, so many disorders, initiation from the disbalance the gut microbiota. So microbiota disbalance, so induce LPS, then activating the or the activated the macrophages. Then the macrophages enter the vesicle, so they induce atherosclerosis. Then enter the liver, so induce fatty liver, and into the island, they induce type 2 diabetes. So looks this pathway is common pathophysiological process. So actually, the macrophage actually planning hold the process of atherosclerosis. And according to this metabolic inflammatory syndrome, so we can personalize and co-treatment of the strategy for different components of MIC, metabolic inflammatory syndrome. So if we divide to 4 study group, we find 4th group that contains 3 another metabolic disorders, including atherosclerosis, the Macleod, or obesity. So for these persons, we don't recommend with insulin, right? Not necessarily the insulin therapy, except they are the containing complications. And the metformin, we recommend big amount, more than the 2 grams per day. So if you, according the BNR and according the different components of metabolic inflammatory syndrome, so maybe can get the best result. Well, so another question is the remission. The ADA, the 2021, the criteria for remission, HbA1c less than 6.5. And for us, we would recommend if the patient is over than 60 years old, the blood goes less than 7 millimole, HbA1c less than 7%. That's enough for remission. So how many years can keep in? If 5 years without any recurrence, I believe this patient called cure. Since the leukemia, if the treatment after the leukemia, then the keeping the 5 years no recurrence, they say this is cure. So I do believe some patients can be cured, but just a few of. This lady, more than 20 years, no any use the low blood glucose drugs, but sometimes using insulin because the acute complications. Since the beta cells not died, just the only differentiation. So for inhibition, there has to ABCD to come to the aberration, the conditions. For example, the antibody should be negative, and the BMI usually bigger than higher than the 25, and the C peptide looks not very bad, and the duration less than 5 years. Those patients easy, possible remission. Also, obesity is the preventable and treatable, and the should be individualized. Idea approved, we wouldn't lose the drugs. If the patient's obesity, BMI is bigger than the 30, or the BMI like bigger than the 27, that with at least one weight-related complications. So this drug can be used, including GLP-1 agonists. Starting therapy for the primary and the secondary the prevention, resulted in the patients with pregnancy, and if the studying the intolerance, then you can choose another compounds, including the second the prevention. If the intolerance the studying, and choose other one. What kind? For example, bempedoic acid. Look at the decrease the low LDL-C. Another question is precision medicine. Actually, right now is getting more easy and more cheaper, more quick, determine the gene mutations. Challenges for the personalized treatment, the very coming from cost of and so another would like to talk the application of AR. So recent years, AR the technology has also rapidly developed in China. For example, the first AR hospital was recently established in Shanghai, and beyond the DeepSeek is widely downloaded and used. And AR the robot that replaces doctors in the filling the patient pills. Filling patient pills is the Chinese traditional method. So this guy is about 500 years ago. The name is Li Shizhen. He's a famous Chinese doctors, traditional doctors. But the filling pills, this is not easy study. So right now it's using robot replace the filling pulse. Actually, according to the screening condition, then they can give the patient to suggest and the diagnosis. And we have invited the new wearers, no wearable, remote body, the index test for promoters, personalized the treatment. Well, so this machine just the screening the island function. So this person, his insulin is normal, but it is a little bit high, but glucose normal. Who is that? with the picture. Using the picture, you can detect 300 index. 300 human body indicate. Well, so here another question that needed discussion. So the health-centered is better or hospital or patient-centered. We discussed we prefer the name is health-centered. Conclusion. I do believe, as I emphasize the personalized the management of type 2 diabetes and of CVD, the patients will be sure more benefits. Thank you for attention.